Sir, now no student is asking any question regarding some investigative modality in case of colon cancer or rectal cancer. When we have a patients of rectal cancer with either liver mets or peritoneal mets. So now recently we have a patient of rectal cancer with liver mets. So how should we progress? Yeah, how should we proceed for the management of these patients?
Okay, so see, the first thing that you have to decide is whether the rectal cancer is obstructing or not obstructing. Because if it is obstructing, you will have to do a upfront colostomy. I would not advise you to try to do a resection. I would advise you to do a colostomy, maybe just a sigmoid loop colostomy, which can be taken down at the time of the final surgery, if ever there's a surgery. And after that, I would refer this patient for chemotherapy plus radiotherapy. Radiotherapy for the local control and chemotherapy to attempt to control the liver mets. Now, the liver mets would depend on whether you have multiple liver mets in both lobes or you have a single liver met in one lobe. If it's a single liver met in one lobe, it is still potentially curable. That is why for colorectal cancer, unlike any other cancer in the body, the staging systems say that the M1 and M2, meaning that M1 is a single metastasis in a single gland, and M2 is multiple metastasis or multiple glands, multiple organ systems involved. So the fact that they've done this is because that with a single metastasis or two metastases confined to a lobe, 25% of these patients are still curable, and you can treat them with curative intent. So if the patient is not obstructed, absolutely no obstruction, then I would first go ahead with chemotherapy, asking the medical oncologist. And chemotherapy also gives you effective local control. And if the patient responds well, then addition of RT to the local control, and then re-image the patient and see the responses, and then decide whether it is worth resecting, or if the liver metastases are significantly reduced in size, maybe then we can go ahead and remove the rectum and then do a liver resection. If the peritoneal mets are confined to over the rectum, then you can still go ahead and do a wide peritonectomy there along with the curative surgery, and then give the patient, and after having given, of course, neoadjuvant treatment, which is an accepted treatment of choice. What I don't want you to do is that when you have a patient with peritoneal secondary advanced cancer, you should not attempt very low anterior resections with consequent morbidity, because these patients require now to be quickly fit for further consolidation chemoradiotherapy. So these patients are best suited for an abdominoperineal resection unless there is really sufficient space to do a good anterior resection which won't leak. Because if you're going to take a chance and do an ultra low and then there's a problem, then the whole disease will have a setback, and whatever chance you had of salvaging will go.
Morning, Ramesh. Sorry, I'm a little late.
No problem.
So Ajay also is here with me. But I think before we go into the debates and controversies, for the sake of students, few basic questions which I will pose on their behalf. So first is these definitions, because they are often asked. What is anterior resection? What is low anterior resection? What is ultra low? And what is coloanal anastomosis?
Okay, of these four terms, three are fairly well described, but the so-called ultra low is not really being classified by anybody. So an anterior resection essentially means that your anastomosis is above the peritoneal reflection. So it is actually to the very uppermost part of the rectum, and therefore it is mostly done for a sigmoid cancer or a descending colon cancer, not really for a rectal cancer. So the low anterior resection is what is done for a rectal cancer. And this essentially means that your anastomosis comes below the peritoneal reflection. So these two terms are well defined. Now, coloanal is well defined, in which case you would have removed part of the internal or part of the sphincters, the internal and external, leaving perhaps only the levator ani to act as the puborectalis sling to act as a sphincter, and you'd have anastomosed it to the anus, which is actually epithelial surface. So it means to the skin of the anal canal. That is where your anastomosis will be at that level. Now, the ultra low is, I would say it varies from people to people, but I usually reserve the term where ultra low when at the end of the anastomosis, when you finish the anastomosis is just about 4 to 5 centimeters above the anal verge, which means that essentially you have perhaps a centimeter of rectum and the rest is all anal canal. So that is what I would think, but that is not well defined in literature. So that is controversial. So some people, even with it is 7 centimeters, they'll say ultra low, to make the operation sound more glorified. So this is a little difficult thing, but I think we should not confuse. We can say low anterior resection. And the fact is that the lower you go, the higher the chances of a leak, the higher the chances of morbidity. That is what is important to remember in anterior resection.
So would it be right for the students to say that an ultra low resection is an anastomosis, say around or a centimeter or two within 2 centimeters of the dentate line?
Yes, that would be approximately correct. Yes. So,
whereas a true coloanal anastomosis will be at the dentate line. So
the true coloanal anastomosis means that you remove the entire rectum. In ultra low, you have a cuff of rectum, perhaps a centimeter long.
Now about the circumferential, intersphincteric and extralevator.
Yeah. So intersphincteric means that you go between the internal and external sphincters, and ideally it should only be done for a T1, perhaps an early T2, but actually both these situations today, I would actually manage with definitive chemoradiotherapy, not neoadjuvant or palliative, but going by the definitive means including the Papillon regimen of an intracavitary radiation, because the results of modern radiation are so good that many of these patients may never require an operation. They may get away with complete organ sparing, which is much better than an intersphincteric dissection, which has a lot of negative points, a lot of soilage, a lot of night incontinence. They are uncomfortable. So I am not a fan of intersphincteric reservations. Cases suitable for that actually sent for definitive chemoradiotherapy, and whatever is left, I just do a local resection and follow them up. And so far, if they are T1 and T2, they have not done badly. But the moment it crosses T2, these patients can no longer be subjected to an intersphincteric resection. They require an abdominoperineal resection. Now, extralevator means that your tumor has crossed the mesorectal fascia completely and is almost abutting the levator ani. So in that case, by removing the mesorectal fascia, you will not get tumor clearance. So you have to go extra levator, go around the levators and then excise the whole thing. And the moment you say extra levator, the resection of the perineum has to be done in the prone position. It cannot be done in the normal lithotomy position for APR, which many people prefer. It has to be done in the prone position, and ideally you should have a plastic surgeon standing with you to do the flap reconstructions, because they will lose a lot of skin, because obviously these are big tumors. So plastic surgeon will usually, nowadays they use local gluteus maximus flaps to close the defect. But it's an operation we do quite rarely now. I mean, I have not done one for maybe a year. The last extralevator I did was about a year ago, because with the advances in radiation and chemotherapy, most of these shrink very well to be controlled by a normal operation.
So again, for the sake of students, the intersphincteric resection, whether it is anterior resection or APR, it can be applied to both?
I wouldn't do it for an APR, because there's no point in doing an intersphincteric resection for an APR. What is the use of leaving a sphincter if there is going to be a permanent colostomy? So I would never
for a future reconstruction.
No, that at the moment it doesn't seem possible.
So intersphincteric is only for a low anterior.
A low where you want to save part of the sphincter, and so these patients should be motivated. One, that I want to try it. Second, they should have good sphincter tone. So if you have a 70-year-old man with poor sphincter tone, never attempt an intersphincteric. He will have a perineal colostomy, and that is worse than a colostomy in a bag.
So if at all you students, you want to mention intersphincteric resection, it will probably be a theoretical option because most of our cases will not be T1 and T2. So you have to keep that in mind, that it is suitable only for early stages, good sphincter function, well-motivated patient, and you have to accept a significant amount of continence issues in the post-operative period.
The continence issues, unfortunately, I have heard a lot of people standing on lecterns in India and saying they're all continent, there is no problem. But if you look through literature carefully, you will find that the majority of studies from Japan, from USA, from Korea, give you incontinence rates ranging from 50 to 90%. So it is not rosy as it looks. And if you go into the net and read patient reports of intersphincteric resection, coloanal anastomosis, you will find that many of them have written that their surgeons informed them and therefore they opted for an APR. In the other case, they were not informed by the surgeon, they went for this, then they were miserable, and then they had to convert to colostomy. Especially if your patient has to travel a lot, has to go out of town for business, likes to go for outdoor sports. An intersphincteric, because he will need to reach a toilet every 1 or 2 hours. Sometimes it's extreme urgency, and may have to wear a diaper for the rest of his life. And it is really, sometimes I think that the consequences of an APR are overrated, and patients with a very badly done ultra-low anterior resection can actually be worse off than a well-done APR.
And you mentioned that in such cases, you would use definitive chemoradiotherapy, even if it is adenocarcinoma, because that is for perianal, anal canal squamous cell carcinoma.
Yeah, so this used to be our idea that adenocarcinomas do not respond to radiation, and we were always skeptical. But then came the studies from, the first studies that came were from Japan. It was not a study in the sense that they didn't allot patients. They just had a group of patients who refused surgery after radiation and chemotherapy because they felt well, and a group whom underwent either AR or anterior resection. When they looked at the 5-year survival, they were the same for both the groups. So the patients who didn't have surgery had exactly the same 5-year survival and recurrence. Then came the major studies from Haber-Gama in Brazil, and she is the one who has shown to the world that radiation therapy is very effective in adenocarcinomas. And now today we believe that adenocarcinoma, because you see, the machines have changed. The quality of radiation given, just like surgeons have improved over the years, the radiation machines are fabulous. They have very little side effects. Now you will remember 30 years ago, a CA cervix patient, after radiation, the entire pubic area will be black, the skin will be thick. Today you see the patient 10 years after one of these IMRTs or IGRTs, you find supple skin, no radiation damage, and there are very little chances of rectal radiation because these are so highly focused that they deliver very little radiation outside the target area.
So since you did mention about Haber-Gama regime, let us discuss that also. Again, a very frequently asked question from students that suppose there is complete response. And when we say complete response, we will go clinical, endoscopic, histological, radiological, biopsy, and if you had done a PET, whatever. So suppose there is complete response.
So we have to classify this as complete clinical response. So this we can no longer see, unless you remove the specimen and do a multiple section, you can never say complete pathological response. This is the first thing students should realize. So even if you do multiple biopsies, PET scan, it's a complete clinical response. Most complete clinical responses are complete pathological responses. I use the word most because in the Mayo Clinic study earlier, much earlier than this, they found that 25% of patients had residual tumor in the specimens when they went ahead and did a resectional surgery. But 75% did not. So what happens if you have a complete clinical response from rectal examination, biopsy, random biopsies, this thing, then what I do personally is if it's a comfortable, see, we also give radiation for patients with a tumor at 10 centimeters, 12 centimeters, who have got an advanced T3 lesion, node positive. Then we give them neoadjuvant RT-CT. Now, even if they have complete response, I would still urge them to have an operation, because I can confidently save the sphincter, maybe with a diverting ileostomy, and then later I can close the diverting ileostomy. So I would ask them to get that tumor out. But let us say that the patient has a complete clinical response and has to have only an APR because of the original location of his tumor. Then there is, it is difficult to advocate somebody to have an APR without any tumor. So many patients will ask. So I tell them that as per the books, we should do an APR. But if you are willing to be under an intense follow-up, which means that for the first year, every 3 months, a rectal examination, anesthesia, multiple random biopsies, and if necessary, a CT scan every 6 months, and maybe a PET scan at the end of 1 year. If they are willing for such tight surveillance, we know that before the metastasis appear, the local recurrence will occur. So it is not true that the metastasis come from the local recurrence. They will have either come from the previous tumor, and they don't come from the local recurrence. So local recurrence is the first thing, and only then it may metastasize. So we should then keep them under follow-up. And if they come back with a tumor, then of course, you have no option but to operate. We have had over the last, since we started adopting this strategy, over the last 5 years, we have about 12 patients on follow-up. And 2 of the patients have subsequently required an APR, 1 for a recurrent tumor and 2 for a patient who had severe anal pain without any obvious tumor. Even at the specimen, there was no tumor, but the pain was so severe that she wanted it out. And we did it. But the other 10 patients are being followed up. They had the first rigorous follow-ups, then 6 monthly follow-ups, now a yearly follow-up. And the longest follow-up we have had is about 4.5 years. Patient is totally tumor-free, and he is without a colostomy. I think that is a major point in favor of this observation of wait and watch, what we call the wait and watch policy.
So, but what would be acceptable to most examiners from the student's point of view? What
I told you, what is acceptable is what I tell the patient, that the ideal treatment is...
No, that is your practice.
No, ideal treatment is resection. So the examiners, if they ask you what should you do with this complete clinical response, you should say that we will still go ahead, despite Haber-Gamma's study, we will still advise the patient to have a resectional operation.
So wait and watch is not an accepted option?
Wait and watch is still a Haber-Gamma driven thing. More and more people, there is actually now a large study in the United States where they put all these patients into one group to wait and watch. And the preliminary reports seem to suggest that they do as well as the ones you operate. So possibly in another 2-3 years, when they publish the results of these surgeries, of these wait and watch, we may find that we have come to a new era in rectal cancer surgery. And that is that many patients may no longer require surgery.
And I'm sure, I hope all students are aware that Dr. Haber-Gamma is a lady, not a...
yeah, lady, and she's a radiotherapist.
Yes, from Brazil. Ajay, you want to?
Yeah, morning, sir. Just few queries for the student's point of view. Very commonly asked question is a Hartmann's procedure. So, Hartmann's procedure with a carcinoma in the rectum causing obstruction, does that mean only a diverting sigmoid colostomy?
No, you cannot
I'm just coming to all the 3 points. Does it mean that resection of the tumor, closing the distal and making a proximal diverting ileostomy? Or does it mean not resecting the tumor and just trying to make a ileostomy out of it? What does the Hartmann's procedure mean?
The Hartmann's procedure is clear. The Hartmann's procedure is where you resect the tumor and you create an end colostomy or an end ileostomy, and the other end is closed and dropped inside the peritoneal cavity. Now, for most rectal cancers, to do a Hartmann's procedure means you have to do either an anterior resection, you have to do an anterior resection of the rectum, and in an obstructed colon with that is when we would normally do this. I don't think it's a good policy to do. So I don't do a Hartmann's ever for a rectal cancer. I always leave the rectal cancer in situ. I don't touch it, because the moment you start touching it, you change the lymphatic pathways, you change the pathways of tumor spread, you handle the tumor. So I leave it alone. and I do a loop colostomy, not an end colostomy, a loop colostomy in the sigmoid, which I can take down at the time of surgery. Now, to do an ileostomy, you will have to prove that the ileocecal valve is incompetent, and somehow it will, I have not found it to be as decompressing in an obstructed colon as colostomy. So I prefer a loop colostomy.
So, one more second aspect, that carcinoma of lower 1/3 of rectum, middle 1/3 of rectum, and upper 1/3 of rectum. What is the present guideline? A neoadjuvant, direct resection, neoadjuvant chemoradiotherapy, only chemotherapy. What is the present guideline for this?
Well, there are no present guidelines as, and when you look at the guidelines, you'll find that there's some difference between the NCCN guidelines and the ESMO guidelines. I tend to follow the ESMO guidelines because they come from a situation like ours where there is a heavy patient load. It's all government funded, so they look at the economics, and the American system is private healthcare. Money is paid by insurance or by patient, so they go in a different way. I think everybody agrees that a T1 or a T2 lesion in the upper third of the rectum, direct resection. Middle third of the rectum, if you have a T1 and T2, direct resection. If you have a T3 in the middle rectum, so the mesorectal fascia involvement, and for this you must have what is known as a high resolution MRI. So CT scans should be abandoned as a standard of deciding the care of rectal cancer locally. It should be only a high resolution pelvic MRI. And high resolution doesn't mean that you need a bigger machine. All it means is you have to expose the patient to a little longer time on the machine and take good pictures, and they will get the images. Then you look at the mesorectal fascia involvement on the MR. So they have classified that as A, B, C, depending on how much depth is involved. And A means that it is about 1, some people say 2 millimeters from the wall of the rectum into the mesorectal fascia. If it is that, T3 MRA, then we follow the European guidelines, which says direct resection, no neoadjuvant chemoradiotherapy. Because neoadjuvant radiotherapy can have a lot of other problems such as anterior section syndrome, genitourinary problems are more after surgery. So in this group, the Europeans have now turned towards direct surgery. But anything T3B and above, any T4 lesion, you will of course require neoadjuvant therapy. The neoadjuvant therapy as given today would be a combination of radiation and chemotherapy. And if you go through the modern literature, even the Americans have now started to accept short course radiotherapy as a standard of care for the neoadjuvant. So you give upfront 5 into 500 centigrade, which is about 2,500 centigrade in 5 days, and then you give them chemotherapy. And instead of giving 5-FU leucovorin, which was sort of an anemic chemotherapy, we now prefer to give FOLFOX as a neoadjuvant chemotherapy, so that your responses are very good. And then you assess 8 weeks minimum from radiation, and then you do a repeat imaging and then see the response, and then you decide on your line of surgical treatment. Now there is the group of T4 lesion, very large, invading adjacent organs, and for that now there is a new term which has come in the last 4 years called total neoadjuvant therapy, TNT they call it. And in this, what they do is actually upfront chemotherapy using FOLFOX for about 6 cycles. Then they give radiation therapy. This radiation therapy could be the standard long course, or it could be the short course. A randomized study from USA itself has proved that the short course is more effective in this situation because it better allows the tolerance of the chemotherapy after the radiation. And then they again continue to finish their full chemo cycle, whatever they had planned, usually about 12 cycles they planned. So the whole thing is given up front, and then the patient is assessed for the resection. And what when we adopted this 3 years ago, what we were surprised is that huge growths, T4 invading the seminal vesicles, shrunk dramatically at the end of the course, and we were able to do a simple anterior resection or an APR, and the patients did quite well. And the treatment is really effective. It just shrinks. And because the patient hasn't had a surgery, they tolerate this very well.
So this is mainly with the long course or with the ultra short course?
We are using the short course. In our institution, and as you know, from my talks on various platforms over the last 25 years, I've always been on the side of the short course because I always believe that it's equivalent to a long course. It is difficult to convince radiation therapists, but I managed to convince them in our hospitals because by a simple expedient that why do radiotherapists want to give a long course? I went into this matter. The reason is that in many institutions, radiotherapists are paid based on the sittings for radiotherapy or on the dose of radiotherapy delivered. That is how they are calculated for their incentives. So I told our hospital that whether they give it for 5 cycles or for 25 days, 2,500 centigrade or 5,000 centigrade, give them the same remuneration for the CA rectum. Let it be radiation for CA rectum and give them the same remuneration. Once we did that, they accepted it. See, it is all economics. And in United States, it's the same problem. This is economically driven. The more radiation the radiation oncologists give, the more time they keep it with them, they get more money. And so if you say that it's not for radiation, but for the treatment of a particular disease, then I think this argument goes on. And that is why it has become popular in Europe, because they're not paid by that. It's all NHS. In England, in France, and Italy, in Germany, it's all national health policies. So they rigorously follow this because it's good for us. And I'm sure Dr. Kapoor would have read the paper which has come from Lucknow, KG Hospital, on short course versus standard radiation. They found that the short course was as effective, probably more effective. And they have actually recommended that in resource-poor countries like ours, we should go for the short course, because we can handle in a government hospital more safe. You can handle 5 times more patients every day if you give short course instead of long course.
I think very validly explained. So, but for the student's point of view, sir, the frequently asked question is there a difference in the duration following the radiation therapy and the surgery, whether it is given ultra short course or a normal course?
It used to be. 20 years ago, if you had asked me this question, I would have answered you yes. Because in the short course, our policy was to give Monday to Friday 5 doses, and on the subsequent Monday or Tuesday to take up the patient for surgery. This was our short course. And now, when you give like this, it is effective in local recurrence. Yes, it brings it down just like long course. But people found that if you wait for 8 weeks following the radiation in a short course, the biological effect of the short course is equivalent to the biological effect of a full long course radiation. So now we have switched our thing for the last now more than 7 years that we do short course, but we no longer operate on the next weekend, but we wait for 2 to 3, 8 weeks to 10 weeks. And during that course, we give them at least 2 cycles of chemotherapy so that to consolidate the effects of radiation.
Sure.
And because they don't have ongoing radiation, they tolerate the chemotherapy better. If you give neoadjuvant for 5 weeks, and during that time you try the chemo, they don't tolerate it as well.
Okay, so another related point which is frequently asked in the question is, following a radiation therapy, you are waiting for 8 weeks, and following a chemotherapy, is there any protocol that you have to wait for such a long duration, or you can operate at a particular time?
No, I would not operate on any patient who has received this last dose of chemo at least 14 days prior to the surgery, because chemo has an effect on the blood cells, immunity. So I would wait for 2 weeks after the end of the chemotherapy before I operate on these patients.
So the important message for all the students is that following any radiation therapy, preferable to wait for 8 weeks, and following most of the chemotherapies, preferably wait for 14 days or for 45 days if the medicine which has been given for a chemotherapy usually causes vasculitis. So there's a difference that it may be from 14 days to
if they have used by any chance bevacizumab, then your period of waiting has to increase, because wound healing will be very poor. You'll have a lot of breakdowns. So you have to wait for at least 28 days once you use bevacizumab.
So Ramesh, this short versus long course radiotherapy, I missed a little bit in between. Now the conventional teaching was that if you have a large bulky growth and you want to downsize it so that your access becomes easier and you may avoid an APR and save the sphincter, you need to give the long course radiation. So does the short course radiation followed by 8 weeks waiting achieve the same, or
Yes.
does it only achieve sterilization?
No, that is the reason why people are shifting to the 8 weeks, because once you give the short course and wait for 8 weeks, the randomized trials that have subsequently come, the Stockholm 3 trial, the Polish 3 trial, and the German, I don't know, one of the newer trials, they've all shown that the response is equal, and in the Stockholm 3 trial, superior to the long course radiotherapy if you wait for 8 weeks. So, see, the thing is that what is people don't understand is that they think of only 2,500 rats against 5,000 rats. That is all, 5,400 grays, let us say. That's all they understand, that this is, therefore the 54 grays should be more effective. But the fact that you give this 2,500 centigrades in 5 days, it has a biological effect equivalent to the 54 centigrade that you give over 28 days. Biological effect. And that for that to occur, you have to wait for 8 weeks. And that is why most of us have started waiting. And we have found with short course radiotherapy and chemotherapy, quite a few cases of complete clinical response. And as I said, some of them are waiting and they've not received a full course. So that argument was true when we were operating within 3 days of short course radiotherapy, because it cannot downstage the tumor. But with waiting for 8 weeks, that argument disappears.
While we are asking questions, students, please chip in, either raise your hand or put your question in the chat. Basically, this is for you only. So about the technical aspects, now the extent of TME, depending on the location of the tumor, whether it is in the upper, mid or lower third.
So I keep it very simple. If it is in the upper third, which means that the lower margin of the tumor is at least 10 centimeters from the anal verge, because we assume the rectum to be 15 centimeters long. So then I would do what is called as a partial mesorectal excision. So I divide the bowel wall and I take 5 centimeters of mesorectum along the bowel wall lower down and remove it. The advantage of this is not only to remove the nodes, but also then you create a narrower rectum to staple across. Otherwise, you'll have to staple across the whole of the mesorectum and you require many more staplers. Usually 3 if you have to staple across the mesorectum. And if you denude this into the muscular play with just a single load of 6 centimeters, a single load, you will be able to divide most of these rectums. Because once you come to the muscular tube, it's not as big as the mesorectum. Mesorectum is the bulk. So that is the upper third. For all middle third and lower third, I think it's a total mesorectal excision. It has to go up to the levator ani, including the tongue of mesorectal tissue that exists below, which Bill Heald has so nicely shown in his operative videos and photographs. That tongue must be removed for any mid-third and lower third lesions.
So which means that the superior surface of the levator has to be cleared of all fibrofatty tissue. Yes. Be exposed. Okay. What about the ureters? Cannulation of ureters? What is your policy? What should be done?
I don't cannulate ureters routinely, but suppose there's because by the time we give radiation, you usually don't have these problems of huge tumors anymore. But let us say that there is a rare case of a GIST which has not completely responded. It's a big tumor. It's filling the pelvis. So what we do is that we give a retrograde cannulation. We ask our urologist to put bilateral retrograde ureteric catheters. And what we do is that through the catheters, we inject indocyanine green when we want to see them. And then we use our indocyanine green imaging and it shows up the ureter beautifully. You can then, Stryker came up with the idea of putting some light into that, a pink light which could be seen. I could not see anything when I tested it the first time they brought it. So I decided that once we had indocyanine green, put the retrograde and put indocyanine green, and it becomes a brilliant green. The whole thing is outlined completely. It's a superb image. And I think that should be the way to go in the future.
So when would you excise the ureter?
If it is directly involved by the tumor, I will always keep mobilizing till I have completely mobilized. And if there's a part which is sticking onto the tumor, I will cut the tumor in the normal tumor above and below. And I'll inform my urologist that I'm going to cut the tumor, so be ready. And when they come, they will do first the ureteric reconstruction, then we do the bowel reconstruction.
But most of these patients would have received radiation because they are advanced lesions. So how do you differentiate whether it is tumor involvement or whether it is radiation-induced desmoplasia?
Fundamental policy in cancer surgery is any dense addition to any structure is a cancerous addition. So if you have to sacrifice 2 centimeters of ureter, the urologist can make it up very easily. So don't hesitate. So if that's the difference between an R0 resection and an R1 resection, you must resect that ureter.
Student Awadh Patel wants to ask 2 questions. What is the role of D3 lymphadenectomy? So before that, can we know what is D1, D2, D3 in rectum?
I have no idea.
I'm also not aware. Ajay, you have any idea?
Does he mean dissecting the internal
let me ask him. Awadh, you want to come in? What do you mean by D3 lymphadenectomy in rectum? Awadh Patel? Okay, while he comes in.
Sir,
then, please come in. Yes.
Sir, some Japanese literature, I heard that internal iliac nodes also they are considering to remove during the rectal surgeries, and they consider that along the internal iliac nodes and the lateral pelvic floor nodes.
Yeah, so that is what I assumed you meant. And the fact is that, frankly, I have never done an internal iliac and lateral pelvic lymphadenectomy in a case of CA rectum, unless the node is large, in which case I sort of remove it, not as a formal dissection, but just along with a specimen to send it, because we consider that this becomes metastatic. The Japanese don't. So this is a fundamental difference between Japan and the rest of the world. And the Koreans also follow the Japanese. So their lymphadenectomies are always radical. But you must remember that when you do this, the chances of impotence, bladder dysfunction is extraordinarily high. It is in the region of 70 to 80%. So you have to, if you want to do, you have to discuss this before with the patient and then only go in for this.
So Awadh, since you have read on this topic and you say that this is called D3, in those reports, what is described as D1 and D2? Can you tell us for our benefit? Do you remember?
No, sir. Exactly, I don't know.
Maybe next time, in the next class, you should read this and tell all of us, because at least I am not aware.
Even I'm not aware. I know that they do lateral pelvic wall and internal, but I am not aware of the D1.
And that point which Dr. Ramesh said, that there is the difference of opinion between the Japanese and almost the rest of the world, because in US again, when these nodes are there, they consider it as distant metastasis, and they don't believe in lateral pelvic lymph node. The other is a very frequently asked question which all of us ask, but probably nobody knows the answer, that what decides the margin of surgery, whether it is the pre-neoadjuvant stage or status, or whether it is the post-neoadjuvant?
Well, I will give you this answer in what is known as reverse logic. The reverse logic is that we have always stated that we can use definitive radiation of long course to downstage the tumor and convert an APR into an anterior section, in which case it means that you are now operating at the new level of tumor. And I think most of us now seem to follow that after the radiation, we look at where the tumor level is, and then we resect with the normal 2 centimeters if possible, if not, then at least a centimeter from there and do. So I think most of us now believe that, see, the reason that this, that it had to be done at the old line was based on head and neck cancer, which is essentially a squamous cell carcinoma, where the bed is ripe for recurrence if you leave the original area. But for adenocarcinomas, it seems to be a different kettle of fish. And that when it recedes, it seems to have completely the same. And whenever we do, and you know that in adenocarcinomas, distal spread is very rare. It's extremely rare. So there should be, once there is a regression, we would go with the regression status and not by the pre, because it's very difficult to go by the pre status, which is very easy to say, I will go by the pre status. Now, how accurately have you measured the distances? Have you measured it in 8 places circumferentially? Have you got a definite length that you say that this is where the tumor was? And unless we have all that data, it is not possible. So I use what is on the table, and that's why I will often have an assistant putting a finger in to guide me whether I've gone below the tumor. And that is a very important technical point, that you must have somebody to do a rectal examination at the time of anterior resection before you apply your stapler to show that you are well clear of the tumor.
In such a scenario, do you get a frozen of the distal margin?
No, I don't get a frozen of the distal margin, because one, it will waste half an hour, and then if it comes positive, it is unlikely to be common. So we go ahead with the anastomosis. Now, once we have gone ahead with the anastomosis, then to revise that becomes difficult. Then I would rely on some more post-op radiation if there is a suture line is positive. Fortunately, down below, we hardly ever find it to be positive. And when it is positive, it is usually a poorly differentiated carcinoma when the distal line is positive. So if it's a poorly differentiated carcinoma, they don't die of local recurrence, they will die of distant metastasis. So really revising it makes no difference.
Dr.
There are two things. There are, I think, two aspects. One is a poorly differentiated, and second is a distally located tumor in the primary evaluation. When we have done a first CT scan, it is a very low-lying tumor, maybe 3 centimeters from the anal verge, and then you give a new adjuvant. Now it has from the 3 centimeters gone to 4 centimeters. You find you have got 1 centimeter extra margin. Now you are resecting it. Now this is the area where I always feel that
this patient, you see, why have you given radiation? Because it is no longer a T1 or a T2. So you have gone for, it's probably somewhere T3 or more. So the question is, if it is 3 centimeters from the anal verge, you can't do an intersphincteric dissection. You are not, because the original shows T3, you should not do all this. So I think this patient is best served in the interest of the patient by an abdominoperineal resection.
Yes. Dr. Chaudhary wants to say something. Sir.
Yeah, Dr. Ramesh, you said that the patients who had complete clinical response following the non-surgical therapy, and then they were subjected, and you are still following that policy, they were subjected to the surgery, and the specimen when sent for histopathology, it was found that 25% of them still had some.
Yeah, that's not my study, that's the Mayo Clinic study.
Yeah. So I just want to know, did they do any retrospective analysis of the findings before the patient was subjected to the surgery?
I can't tell you the exact figures.
Who were thought to be having complete clinical response, they had any telltale signs of that, yeah, these are some features, we should have gone ahead with little more therapy before we subjected the patient to the surgery?
Now, this paper is over 25 years old. It's not a new paper. So obviously they were using radiation machines and chemotherapy, which was not what we use today. So I think that the relevance of that study could be called into question with the modern radiation and modern chemotherapy that we use. Now, when we look at our own specimens and the ones who have had a complete clinical response, and where we have managed to do an abdominal anterior resection, and therefore they agreed for the surgery, we found that a large percentage, about 2/3, had no tumor, no nodes involved, nothing, complete pathological response. But some of them had. So I think that it is never, I don't think that there's any way we can say 100% sure that there is no tumor cell lying there. We don't have it in our hands at the moment. There's no test to tell us that. Oh. So we make a judgment call based on, I think, the sphincter. If you can definitely say the sphincter and have a comfortable anterior section, I would go ahead and advise them to strongly have a surgery. My body language would indicate that I wanted them to be operated. But if they have to have an abdominoperineal and, with the what they associate as social stigmas and other problems. If they have a complete clinical response and I've done multiple biopsies and they're willing to come for follow-up, I give them that option. And not that all of them take. There are percentage of patients who come and say, no, you have said the literature says this, I will have an APR. Even they have had APR. So actually I had a Muslim lady whom we had decided, and they went back, came and said, no, we have an APR. We don't want cancer. So they underwent an APR. Unfortunately, she had residual tumor. So it was worth it. So there is no way we are going to do. So to some extent, this is going to be a gamble.
Right.
It's a gamble. And but the good news is that first local recurrence will occur and then only it will spread. So if you keep them under intense follow-up, you'll find them as soon as the local recurrence and you do the surgery, you will get almost equal results to doing immediate surgery.
One more question. This regarding the short course intense radiotherapy versus the long term regular radiotherapy. The patient tolerance to the short course is as good as for the long term, or the patient tolerance makes hampers your this short term radiotherapy?
No, the tolerance is excellent. The only problem we felt was in the last 20 years ago when we used to operate 3 days after the surgery. We would find that they would have post-operative fever, infections, perineal infections immediately. But once you wait for the 8 weeks, whether you do long course or short course, the results are the same as far as healing and everything is concerned. So it is not a concern, and our patients tolerate it very well. But most important is that, see, my patients come from a radius of about 300 kilometers. Okay, now if they have to take a long course, which means 25 days, they have to stay in the city here for 25 days, come every day, which means they have to pay either a hotel or a house charge or whatever it is, and then give so much money. Or in 5 days, they'll just get admitted in the hospital, finish it and go home. So they seem to tolerate it and they seem to like it much better.
Since we have been asking the questions repeatedly, I just request the resident, because most of the questions which will come from us will be at a higher end level questions rather than the routine questions which are expected from you, from the examiner. So, and your queries, I would request the residents, all the students who are there, please make more questions, raise your hands and keep on asking. No question is a small question. That is important for you. That is why they cut this classes. And therefore, you have the most eminent teacher of the country with you, who is giving his time, precious time, just for you people. So please ask more questions.
What about exenteration, Ramesh?
Pelvic exenteration is something that we do for, I have done just 2 cases in my entire life. It's not something I have done. Patients who have been willing, who have had local recurrence from CA rectum and were miserable because of the pain and everything. I went and did a because they were also having bladder and urethra. So along with the urologist, we did a pelvic exenteration. And then we, in one patient, we put the sigmoid colostomy and put both the ureters into the sigmoid colostomy, the first case. And then we had a miserable post period because the patients have a lot of electrolyte disturbances, infections, problems. So the next patient, we did a separate colostomy and a separate ileal conduit for the thing. But both patients died within about 2 years after the surgery of the recurrent disease in various places. So it is not something I have an experience about, but rarely can be done if the patient is willing to have a double ostomy. I think a double ostomy is a must.
Student Sudhakar Rangaswamy wants to know that CA rectosigmoid with bladder involvement, and our plan is to give neoadjuvant treatment. Which diversion, loop, ileostomy or colostomy?
See, if you have a bladder infiltration, if you already have a formed fistula, and you approve it, that is one scenario. The other scenario is that usually the sigmoid dome gets stuck to the dome of the bladder, and it is not yet infiltrated, but it might infiltrate. Now, in these patients, if you give neoadjuvant, there's chance that as the tumor necroses, it will form a fistula. So this is one group of patients where if it is clearly a resectable, and most of the times a sigmoid growth on the fundus of the bladder is usually a clearly resectable tumor, even though it is T4. And I would go for a wide resection with the resection of the cuff of bladder, then close the cuff of bladder and do either the anastomosis with an end ileostomy, with a loop ileostomy, and then give them post-op adjuvant treatment. Because rectosigmoid, usually you don't require radiotherapy, so you require only chemotherapy. We can give that in the adjuvant setting.
Awad wants to know that obstructed rectal cancer, which is the preferred method of diversion again. Although I must add, now you have the option of stenting also.
Yeah, not for rectal cancer. Sorry, stenting is not a good option for rectal cancer because the rectal cancers are low, and if the stent is very low, it doesn't work and it causes a lot of irritation to the patient. And sometimes if it is almost at the anal thing, it'll keep it dilated, so the patient will be incontinent. So don't put a stent for rectal. Stent is good for a descending colon growth. Is the best for a descending colon growth if it is obstructed, to convert it into a straight surgery. But for rectum, best is to do a sigmoid colostomy. You'll have complete diversion. You don't touch the tumor. You don't touch the area at all. You don't damage it, and then go for your proper neoadjuvant with radiation chemotherapy. Because now that they have a colostomy, you can do all that, and then do a surgery where you can take down the sigmoid colostomy at the time of surgery and bring the descending colon for the anastomosis.
Since there's a question of stoma, which we are discussing right now, just a small query, sir. What is the your policy when you are doing a normal resection of sigmoid colon? Do you make a stoma? For a upper rectal resection, we are doing a stoma. Lower anterior resection, we are doing a stoma, or ultra low anterior resection, we are doing a stoma. Okay. Which one do you like to cover with the stoma? Just for the student's perspective.
Okay. Let us take a sigmoid colon growth first. If I always prepare my patients, so they should be non-obstructed. So this will be non-obstructed patient. So I would have given a mechanical bowel preparation and given oral antibiotics the day before, and then give IV antibiotics on table. This is my preparation. Now it's sort of the world over, people have shifted back to mechanical preparation and antibiotic preparation. So I do that. It's a clean colon. I will do a sigmoid resection. I will not cover it with any ostomy. Usually, if it is, and I will do a leak test. If there is no leakage, it has come out nicely, anastomosis, I would not do a diversion. A low anterior resection, non-obstructing, has received neoadjuvant, but the anastomosis is say 7-8 centimeters. I would do the anastomosis. If the anastomosis is got any sign of doubt, I will do an ileostomy. If there is no sign of a doubt, I will leave it around and wait and watch policy. What is a sign of doubt? Signs of doubt are: one, when you remove the stapler, you find that the donut is incomplete in one side. So then that means that somewhere there's been a misfiring. So I will always cover it with an ileostomy. When I do the betadine, first I do a betadine leak test, betadine saline. And if that leaks, obviously you have to do an ileostomy. If you can take a couple of stitches, if you see the hole, it's okay. But most of the time you can't see it. A lot of fat, epiploicates in the pelvis, you can't see it. So just do a diversion ileostomy and come. Third, if the betadine doesn't leak, but the air leaks, again I will do an ileostomy. I will not attempt to try to close the hole. Just do an ileostomy leak. Now, people used to think that ileostomies only mitigate a leak, but they don't prevent a leak. But current studies show us that ileostomies reduce the leak rate. So if at any stage you are prepared to do an ileostomy preoperatively, you must prepare the bowel. This is very important. That ileostomy patients must have a prepared bowel, because if they don't have, then even if you do an ileostomy, the remaining motion in the colon can cause severe sepsis, leak, and all the problems. So you must prepare them and have a clean colon. If you don't, you can on the table then decide, then you can do an on the table irrigation, clear the motion, and then do the anastomosis, and then do an ileostomy.
So is the message given is that whatever anastomosis you do, if it is a leak test does not show, or if you're comfortable with anastomy, you will never cover with a stoma?
Sorry, I didn't come to my last point. I still,
yes.
Yeah. The final point that was asked was for the low anterior resection. So if the anastomosis is within 5 centimeters of the anal verge, or 5 or 6 centimeters, has had neoadjuvant chemoradiotherapy prior, I always do an ostomy. There are some people who don't do it if it's all right, but even if it's a leak proof, everything is negative, I will always do an ileostomy, because these anastomosis have a higher chance of leaking. And once they leak, you can't really salvage it. You have to do an abdominoperineal resection and have a permanent ostomy. So I like to do an ileostomy, and I take consent for it before the surgery from there. And around the world, most people with neoadjuvant chemoradiation perform an ileostomy, especially in the United States and in Europe, where they don't want any litigation and complication. And the Japanese and the Koreans who don't get litigated at all, they are a little more aggressive and they do it without it. And I know that some Indian surgeons claim that they don't do an ostomy routinely, even if it's a low anterior section. I don't subscribe to that view. I do it because I work in a private sector, and if there is a leak, the cost of treatment skyrockets, and then the patient will suddenly be taken away without any further treatment to die somewhere because they no longer have money. So ostomy is not only a life-saving, but it's also a financial saving procedure.
I think we will close. Thank you very much, Dr. Ramesh, for giving your time, and I'm sure students.
There's one question from Rohit on post-LAR with ileostomy, patient has a leak with a collection in the pelvis. So if the collection is seen on a CT scan, it is not big, I would get the radiologist to put a pigtail catheter and drain it, because you already have a protective ileostomy. If it's a big leak, then perhaps I would go in and wash that area, put a wide drain there, come out and leave the ileostomy in situ.
Thank you. Thank you on behalf of all the students and the department. Thank you very much.
Thank you, Vinay.
Thank you.
Pleasure. My pleasure.
Okay, we will close. Yeah.
Is any criteria for this covering ileostomy?
Dr. Chaube wants to know, do you give consideration to age of the patient when you decide whether to give a covering stoma, elderly patient?
Previously, I used to do ostomies, but then now when we do it for some limited patients who have got very low anastomosis, see, the fear is not of the ileostomy. My fear is that when you go to close the colostomy, the colostomy's marginal artery is what is going to be supplying your low anastomosis, and that gets damaged at that time, then the whole the colon will necrose. So I prefer to do an ileostomy. It's much simpler. And with modern gadgets and everything, we can manage them. Yes, the initial problems of ileostomy are more, but then it's only for 3 months and we convince the patient and they manage.
No, age I will ask.
Age I don't care. No, even elderly patients, I do an ileostomy.
Okay. You you cover with the age, you cover with the state, ileostomy.
Yeah, any age. I do ileostomy only now.
Okay.
Okay, thank you. Thank you, Ramesh.
Thank you.